Hi, welcome to Facebook Live. My name is Tamara Beliard. March is Colorectal Cancer Awareness Month, and today we have an outstanding panel of experts to help us understand what that means. But before I get to that, I want to remind you to ask us questions, type in your questions, your comments, concerns, and we'll try to get through them during the show. Welcome, thank you. We have Dr. Antonio Ucar, medical oncologist at Miami Cancer Institute. Dr. Michael Chuong, a radiation oncologist at Miami Cancer Institute.
Hi.
And Dr. Eduardo Krajewski, clinical section chief for colorectal at West Kendall Baptist Hospital. It's a long title.
Yes.
Welcome and thank you.
Thank you. Thank you. Thank
So
you.
Dr. Ucar, I'm going to start with you. We hear that colon cancer is oftentimes called the silent cancer. Can you tell us why? And colon cancer is another word for colorectal cancer, is that right?
Well, we talk about colorectal cancer, usually referring to the whole lower part of the gastrointestinal tract, what we call the large bowel. The last portion is the rectum. And there are some implications with regards to the treatment when the tumors are located in the rectum, and the treatment might be a little different than the tumors that are higher up in the colon or more proximal in the colon. The frequency of this cancer, it's high in the United States. It's the second cancer in women and the third cancer in men. About 145,000 cases per year are expected in 2019. 100,000 are colon cancer and about 45,000 are rectal cancer.
Okay.
You can call it silent killer in the sense that many times when the cancer is early, you might not have any symptoms, or you might have minimal symptoms. It's not rare that the cancer is diagnosed after the primary physician that is evaluating a patient detects iron deficiency anemia, anemia due to lack of iron without any obvious explanation. In an adult, especially in men or in women after the menopause, the most common source of blood loss is the gastrointestinal tract, and that can lead to iron deficiencies. So that can be an early clue. But if you wait until the patient becomes symptomatic to act on the symptoms, that might be a sign that the cancer is actually a little advanced, more or less advanced, because that's usually the case with cancer. When you have symptoms, the cancer is advanced.
Right, and what are some of the symptoms that you see most frequently?
So as I mentioned before, you can have an asymptomatic patient that is detected to have colon cancer on a screening colonoscopy. Okay. And that's one of the reasons why we emphasize on the use of screening methods for early detection of colon cancer. One of the main ones is the colonoscopy. Other symptoms could be abdominal pain, rectal bleeding, dark stools, which could be related to digested blood. As I mentioned, iron deficiency anemia, or a change in the bowel habit. So some people develop diarrhea or constipation, or a combination of both. And more advanced cases, sometimes they actually present to the emergency room already with far advanced symptoms, like abdominal distension, inability to move their bowels, nausea, vomiting.
Wow.
And that could be due to bowel obstruction or even perforation leading to peritonitis. And
at that point, it's very advanced.
It's advanced. There's still hope. Right. We always have hope, even with the most advanced cases, but the ideal situation is to detect it earlier, because the curability will be a lot higher.
That's great. That's good. And who's at risk? Can you talk to us a little bit about who's at risk? Meaning, genetics, lifestyle.
The main two factors that are considered are the patient's age, because as we age, the risk of colorectal cancer increases. About 90% of the cases occur after the age of 50.
90% occurs after the age of 50.
Yes.
Okay.
And we have actually seen since the 1990s that the incidence of colorectal cancer has decreased in general at about a 2% rate per year. But for patients younger than 50, we have actually seen an increase, mostly due to increased diagnosis of rectal cancer, of left-sided colon cancer. So age is an important factor we look at, and for patients with standard risk for colorectal cancer, that is the patients that don't have any special circumstances that increase the risk for cancer, we recommend to start screening colonoscopy at age. Screening test could be colonoscopy, could be fecal occult blood, right, at age 45 or 50. And from there, based on the results of the
right,
test, you might decide to do it more frequently or not as frequently.
We'll talk about.
But other factors, of course, are the presence of cancer in the family. So family history is also an important factor. Those are the two most important factors. And then there are other things to consider. Diet, high in red meats, saturated fats, processed meats, refined sugars or refined carbohydrates like refined flour. Those in general are considered to have higher risk for colorectal cancer. Sedentary lifestyle, obesity, diabetes,
so
those are risk factors.
Is obviously very helpful.
That's considered to be a very important factor, and that's why we think we're seeing a relatively high frequency of colorectal cancer still in developed countries.
Okay. Now, Dr. Krajewski, once they get diagnosed, they come to you.
Correct.
And so can you talk to us about what that process is like once they come to your office?
Sure. Well, first of all, what you need to understand is that the earliest we find these cancers, the higher the chances of curability.
Okay.
So that's what we stress screening. And as Dr. Ucar spoke about, we stratify patients in different risk groups. And usually, up to very recently, the starting age for screening in a regular patient without any risk factors was 50 years old. And those are the guidelines, and they still remain the guidelines. Very recently, the American Cancer Society realized that we're seeing cancers in younger individuals that tend to be a little more aggressive, and they recently recommended a screening at age 45. The guidelines have not changed, but the recommendations did. So when a patient comes, so in 2019, and for the past few decades, the best chance a patient has to get cured from an early cancer is surgery. This might change in the future with all our newer advancements, but in 2018, still surgery is the best form of therapy for an early cancer, with curability rates from 80 to 90% if the cancer is caught earlier. So basically, when a patient comes to me, it's usually sent to me either by a gastroenterologist, or sometimes I do the screening colonoscopy and I do find the cancer.
So colonoscopy is still the best.
Sure. So let's talk a little bit about the different the different tools that we have to screen a patient. Okay. So we think that most of the colorectal cancers, they do arise from a small lesion called a polyp.
Okay.
And we think that it takes from the normal lining of the colon to turn into a small polyp to turn into a big cancer. It takes about 10 years. And so we have different forms and methods to screen for colorectal cancer. The gold standard, the best one that we have available as today, it's a colonoscopy. Why? Because with the colonoscopy, we can survey all of the lining of the colon, and if we find a lesion, a polyp, before it turns into a cancer, we just remove it right there and we prevent cancer. The other advantage of screening patients early is that if we find a cancer, usually we find it at an earlier stage, so the earlier we get it, the higher the chance of curability. There are other forms of screening tools, such as the short version of the colonoscopy, which is called the sigmoidoscopy.
How do you say that? Say that
sigmoidoscopy, in which we screen just the half of the colon. But it has a disadvantage that we don't screen the rest of the colon.
Why would you do just half?
Well, in patients that are lower risk for colon cancer, younger patients, we just screen. And it has the advantage you don't need to take the nasty bowel preparation that you have to go through when you prep for a colonoscopy. Other forms of therapy, of screening, the virtual colonoscopy, the famous virtual colonoscopy, which is a CAT scan. That's what it is. It's a CAT scan.
You still have to prep and drink the drink or no?
You have to prep with a different prep, something that is much better tolerated than a full prep for a colonoscopy.
It's flavored?
I guess it's flavored. Yes, it is. So, but the amount of liquid you have to take is less. It has the advantage that when you do the CAT scan, you're able to see other organs as well that you're not able to see with the colonoscopy. So every so often we find a patient that had a virtual colonoscopy and the colon was normal, but incidentally we find other form of tumors or other problems outside the colon, things that you will miss with a colonoscopy. But if you find a colon polyp in a virtual colonoscopy, well, guess what? You need a colonoscopy because you need to remove it.
So you have to go back to get the colonoscopy.
Other forms of therapy are the stool examinations, like the Cologuard, which is something that is newer.
It's called Cologuard.
Cologuard.
Right.
And it's it gives you like a sensitivity of about 92% in finding these advanced adenomas, advanced polyps, and cancer. As an example, today, but what happens if you have a positive Cologuard? You need a colonoscopy.
So it all leads back to a colonoscopy.
Yes, colonoscopy is the gold standard. Colonoscopies are a relatively safe procedure.
And men, women, everybody.
Everybody.
Can,
correct. And very low rate of complications, and patients do really, really well. It takes about 10 minutes to do. The patient is completely asleep, does not feel a thing, and then they go home and just move on with their day. The worst day of the colonoscopy is the day before, when you have to take this bowel preparation.
To cleanse?
To cleanse. But it's what we have available nowadays to cleanse your colon is much better than what we have available a few years back. So it's much better tolerated. We strongly believe that any form of screening is better than none. So if a patient does not want to do a colonoscopy for X or Y reason, we recommend some form of therapy because we really find cancers that way. So the patients come to my office now with a diagnosis of a new diagnosis of colorectal cancer. Then we need to stage the patient, and by doing so, we do a CAT scan of their chest, abdomen, and pelvis, because the main sites of metastasis, of spread, are the liver and the lungs. So we always screen those sites first, and then we have an idea where we're standing. In terms of surgery, you know, at MCI, at Baptist, we offer basically all forms of surgical techniques available that run from the classic open surgery to the laparoscopic approach with all of its variations to robotic surgery. And they're all tools, and we kind of tailor the form of the technique, or the surgical technique that we're going to offer to a particular patient. I mean, to the patient per se, because some patients are candidates for one form and not the other, etc. Once I finish with the surgery, then I wait for the final pathology to stage a patient and see where we're standing. And 100% of my patients are sent afterwards to the medical oncologist, and he's the one to take, or she's the one that takes the lead in terms of what follows. So we're going to come back because I have some questions for you, but I want to get to Dr. Chuong and ask him, we know that cancer is not a one size fits all treatment, you know, plan. Can you walk us through how patients at Miami Cancer Institute get an individualized plan customized by their diagnosis?
Sure, no, absolutely. So at MCI, we have a multidisciplinary weekly tumor board where all of the experts, including Dr. Krajewski, Dr. Ucar, and many others who represent different aspects of therapy, as well as experts in radiology and pathology. We all meet together on a weekly basis to discuss new cases, and everything about the case is reviewed in detail. So that includes the pathology report, the scans that we all look at together, and then we have a discussion about what we think are the different recommendations that could be made, what are the evidence maybe behind one or another, and then ultimately there was a consensus recommendation that we would make for the patient. And so, it's really a great way to have a group of experts come together and really have one consensus opinion that the patient can kind of take, and consider.
That's pretty amazing. So you get together, you talk, you look at the data, you talk about your experiences, and together you come up with the plan. Is that what you're saying?
Exactly. And and the other benefit that I think that the patients have who come to us is that our group, just like many other groups, are site specialized at our institution. So for example, I predominantly treat patients with GI cancers like colon cancer or colorectal cancer and others, just like Dr. Krajewski and Dr. Ucar are also very specialized. So I think being able to focus on one area and know the literature and sort of know the recommendations that we should be making, because that's mostly or if not all of what we do every day, I think that really benefits our patients.
That's great. Do you have like a story or a patient story that you were like a successful story? I mean, I'm sure they have different types of stories, but anything in particular that you can share where it was, a difficult case, but,
Sure.
happy ending, anything that you can walk us through?
So fortunately, many patients with colorectal cancer, even if they have advanced disease, can be cured with advanced technologies that we, many times, all of our disciplines, surgery, radiation, and chemotherapy might come together to hopefully cure these patients. And so that can certainly happen in addition to the early stage cases. But, one case that comes to my mind is a patient who had a locally advanced rectal cancer and was treated somewhere else before and had radiation and chemotherapy, had surgery, and there was no evidence that there was any cancer left behind. But a few years later, the patient ended up having some symptoms, some pain, had a CT scan, and unfortunately there was some new tumor that had regrown where the rectum was before, after the surgery was taken out. And so it's a very difficult situation because it already had aggressive therapy, had a lot of radiation before. So the patient was actually sent to us to talk about maybe giving more treatment in the form of radiation or maybe something else. So we have something called Proton Therapy at MCI, which is a very specialized form of radiation. There are only a handful of centers in the entire world, let alone the US, that have this technology. Wow. And it allows us to deliver much more precise radiation with giving less radiation actually to the areas around the tumor that we need to treat, which is very important for some patients who have already had a lot of radiation and now we don't want to increase the risk of complications. So we treated this patient with actually quite a high dose of with radiation therapy in the what's called the re-radiation setting, sort of the second time around, which is much more of a higher risk procedure. The patient received some chemotherapy at the same time to help the radiation work a little bit better. And unfortunately, he wasn't a surgical candidate, but in cases where we can do surgery afterwards, we know that patients generally have a better outcome, better survival. But this patient now is about 6 months out. He really had no side effects from his treatment, and his tumor has responded nicely. So, it's shows you some of the power of the advanced state-of-the-art technology that we have at MCI.
That's really great. And do we do a lot of clinical trials as well in Miami Cancer Institute?
Oh, absolutely. So one thing that we are able to offer are state-of-the-art, cutting-edge clinical trials for people who have very difficult diseases or very challenging situations where we think that the standard of care might, the outcomes typically are not as good as we would like them to be. For each patient, we certainly consider whether clinical trials are available, and many of the most advanced clinical trials that are out there are available at MCI, and maybe I'll let the others chime in. But one thing that we're proud of is being a partner with Memorial Sloan Kettering as part of the MSK Alliance. So clinical trials that, say, for example, are available at MSK in New York, many of those we're able to open in Miami at MCI and have patients access those state-of-the-art trials here in South Florida as well as up in New York.
That's wonderful. So I want to open a question to all of you, and just everybody chime in whenever. Is there an age that is too early to get a colonoscopy? I actually had one when I was 25 because there was history in my family. it wasn't covered by insurance. At the time, they said, I was too early, but I still did it, and it's okay, and it turned out to be fine. But is there an age that it's too early? We know that it changes all the time, the recommendations on when to get screening for the different cancers. Is there an age that's too early? Do you see early, ages that don't fit the criteria that that they recommend?
Well, it's all based on risk. What is your risk to develop a colon cancer?
Right.
There are some genetic diseases like what we call FAP, that stands for familial adenomatous polyposis. Those patients have a 100% chances of having colon cancer by age 40. So we start screening them very early in life, at their early teens.
Wow. And how do you find out if you?
Well,
how can you find out?
Well, usually the patient comes bleeding, mucus discharge, or they already have a family member with the disease, and they're tested genetically, and then we know that they do have the condition, and then we start very early screening. There are other forms of genetic diseases like the hereditary Nonpolyposis colon cancer syndrome, which usually refer as Lynch syndrome. We start earlier screening. When you have a first-degree relative with colon cancer, we usually start the screening 10 years ahead or younger than when the patient got diagnosed with cancer. As an example, if in your family or your relative got colon cancer at age 35, then we go 10 years ahead of time, and then we screen them at age 25. So there's not an early or too early age to start screening, but you need to understand that the likelihood of a average risk person to develop colon cancer in their teens or 20s is very, very small, but not impossible. Right now we're treating together a 27-year-old woman with widely metastatic disease, and she's doing really well. Another thing that you need to understand is nowadays we see the treatment of advanced colon cancer as a team approach, as we mentioned before, and we just meet together with different specialties, and in the past, the chances of a patient with really advanced disease to be alive and well in 5 years was about 10%. That means that 1 out of 10 patients will be alive and well in 5 years. The rest will just succumb to their disease. Nowadays, it's changing because we're offering more aggressive forms of therapy, including radiation therapy, interventional radiology techniques to deliver forms of therapy locally to the metastatic site, more surgery, and chemotherapy. We're getting better. We're getting better, and we're going to get to a point that we're going to...
Yeah, absolutely. I mean, I think to really add on that, before, some years ago, it was thought that all patients who had stage 4 disease, if there was a tumor that had spread to the liver, these were completely incurable patients, okay? I think the thinking has changed now. So patients who have limited, say, just 1 or 2 areas somewhere outside of, say, the colon or the rectum, say you have 1 area in the liver, those patients actually, we would say, potentially have a chance for cure because of the advancements in the technology that are there around radiation or, interventional radiology techniques. And we know that, the advanced treatments that we offer at MCI, there are a number of studies that have shown improvements in survival and even cures using some of these treatments. So for an example, there was a randomized trial, so some patients who got chemotherapy who had metastatic disease, some patients got chemotherapy plus something called SBRT or SABR, which is very, very high dose pinpoint radiation, which is what we can deliver on our most state-of-the-art machines. And the patients who, keep in mind, these were metastatic patients, stage 4 disease patients with tumors that had spread. There was a significant benefit in terms of prolonging life, actually, with the addition of this state-of-the-art, pinpoint radiation. So things like that we can offer patients have really sort of changed the landscape of patients with sort of stage 4 disease.
So that's great. It means that if somebody gets diagnosed with colorectal cancer, they should feel optimistic that there's a lot that could go in and the success can happen and the disease can.
I think that even for the patients that are not cured, we make very strong effort nowadays in trying to get rid of as much disease as possible. And over the years, the treatment of metastatic colon cancer has evolved, and metastatic colon cancer has now become more of a chronic type of disease, where we can jump from one chemotherapy or immunotherapy to a different one, or one type of surgery or interventional procedure to a different one also, to try to get the person going and living the best quality of life possible.
That's wonderful. That's very encouraging to know that. So we have our first question. Virtual colonoscopies, are they effective as a regular colonoscopy? You mentioned it earlier, but it's good to
just
recap.
Just to recap again,
Yes.
a virtual colonoscopy is no more than a CAT scan with a different protocol. And it's very good in finding lesions that are about 1 centimeter, between 5 millimeters to 1 centimeter in size and diameter. So the question is it as good as a colonoscopy?
Right.
Probably not, because if we find a lesion during the virtual colonoscopy, you will still need a colonoscopy just to remove the lesion. So in my opinion, and I think and across the board, colonoscopy continues to be the best form of screening.
Because the virtual one, you're just kind of looking through the scan, versus the colonoscopy, you actually go in there and can remove.
Correct.
Okay.
So what they do is, after they do the images of the CAT scan, they do like a 3D reconstruction on the monitor, and the radiologist can just basically look at the colon and see if we have any polyps or not.
Okay, great. We have another question for Dr. Chuong. Are there qualifications to receive protein therapy? And that's a great question.
Yeah, so I mentioned before something called proton therapy, which is a much more advanced form of radiation, which is more targeted. So not all patients with colorectal cancer or other types of cancers necessarily will benefit from proton therapy. It will be certain patients, and what I generally tell patients is that a physician who is has expertise in proton therapy, you should really have an in-depth conversation and discussion and review all of the records. But in some patients, for example, who have had previous radiation therapy and need more treatment in the same area, proton therapy really is naturally something that we would think about, because we can deliver much less radiation to tissues that receive maybe the bowel or the bladder that we are trying not to treat again. That would be a reason for proton therapy. There are some others. That really is sort of a case-by-case basis. And again, because we have, fortunately we have the most advanced radiotherapy program and the most state-of-the-art equipment under one roof anywhere in the world, as far as I'm aware. So I'm able to choose, yes, proton therapy is right for you, but if it's not, I can tell you that this other state-of-the-art treatment like CyberKnife or yttrium-90 radioembolization or whatever, there's a number of different things that we can offer patients. So we can really tailor the treatment to the patient and not try to make, say everybody benefits from proton therapy.
That's wonderful. It's good to know. Okay, life after colon cancer, what does it look like?
I think that not all colon cancers are the same. So you cannot really generalize, but I would say that for most of the patients that have regular surgery for colon cancer, they can go back to a lifestyle that was very close to what they have before the diagnosis of cancer was made. There are some exceptions, patients that need extensive surgeries or that need a very aggressive treatment or the combination of radiation. I would say that, for example, for rectal cancer patients, there might be some limitations that persist for longer, because they are usually treated with multimodality therapy. Most of the patients with rectal cancer, unless it's very early, are treated with a combination of chemotherapy, radiation therapy, and surgery. So you are adding the potential toxicities of those three regimens. And of course, we're very aggressive in trying to get rid of the disease, and sometimes you have to deal with some long-term toxicities. But one thing I can say in rectal cancer in particular is that with the new modalities that we're using in radiation therapy and with the new machines that spare the normal tissue around the tumor, we're seeing less and less toxic side effects from the treatment. So even what a patient experienced, let's say, 10 years ago, is different to what the patients experience now with the machines that we have available at our center.
So there's been a lot of advancements, and Miami Cancer Institute has the best of the new technologies.
Yeah, I mean, we really have the most state-of-the-art for all disciplines that we can offer patients.
That's wonderful. Another question from Vivian. I'm 76 and I have problems with my rectum. What do I do?
What problem?
Yes, what problem, Vivian? Write us back. What problem specifically? Yeah. But in general, somebody comes in and says, because that happens, right? You come into the doctor's office and, you know, person says, I have a headache. Is it a tumor? Yeah. So I think that's what they're getting at.
Well, usually when they come to my office, you know, the main complaints are basically maybe rectal bleeding, mucus discharge, changes in their bowel habits. They cannot empty their rectum. Some patients come here with fecal incontinence, and what we do is we just we do colonoscopy.
You got to do colonoscopy.
And then we see what's going on. Okay. And then we know exactly what's going on.
Okay. And, you know, I was curious, once you start a treatment or when you do the operation, how long is the recovery for the patients?
It depends on how we define as a recovery.
When can they get back to work?
You know, but it depends on the on the disease per se. Okay. But let's say overall, a patient could expect to be back at work in 2 or 3 weeks after the surgery. Usually to drive again, it's about a 2 weeks ordeal. To really exercise briskly and forcefully, it's about 6 to 8 weeks.
6 to 8 weeks.
Yeah, and for the patient to be completely recovered from surgery, it's about a 3 months ordeal. But it's not that the patient is suffering for 3 months. You know, after 2 weeks, the patients they do feel really, really good after surgery.
Okay, and the treatment starts after that 3 months or during the recovery?
Well, the treatment, you mean, so not all patients require more therapy after surgery. Okay. The more advanced, the higher the likelihood of so.
Got it.
So usually we wait 3 or 4 weeks prior to starting. Yeah, because we really need to make sure all the wounds are completely healed.
Got it.
After surgery, just to start with further therapy.
Okay, great. Okay, we have another question from Marlene. What happens when your rectum is prolapsed due to a colonoscopy? Should I be concerned of a puncture of a colon?
No, not at all. Not at all. When having a colonic perforation after a colonoscopy is something that is rather rare. It happens once every 1,000 colonoscopies. Of course, being this the only thing we do, we see, you know, every 2 or 3 times a year we see a colonic perforation after a colonoscopy. The rectum being prolapsed after the colonoscopy is not a sign of a perforation. It usually happens because of the bowel preparation the day before, because the patients have to actually strain a lot just to have those bowel movements, and sometimes the rectum prolapses. But it's usually not a problem. It usually reduces spontaneously, and if it doesn't, just come and see us, and we'll diagnose it.
Okay. I had a question about nutrition, and you mentioned some of the preventive measures that we can take to, you know, to lower our chances of having this disease. Can you recap again what you mentioned? You said, you know, try to stay away from red meat.
So I would say, yeah, stay away from red meats, processed meats like bacon, ham, sausage. Also refined carbohydrates, or what we call white foods, which is white flour, white sugar. Those refined products tend to increase the risk in general, and avoid the high-calorie diet in general. It's better to move towards more vegetables, fruits, poultry, fish.
Okay, great. Dr. Chuong, do you have any last thoughts before you go?
No, I mean, I would just sort of reemphasize, and actually, you know, I feel fortunate to be in such a, you know, an institution where, and certainly in a group where, you know, we have, you know, we've said before, the state of the art, but also I think it's sort of, the CEO of the Cancer Center, Mike Zinner, is always, you know, likes to say, high tech, high touch, you know. And so I think the providers among the different disciplines who care for these patients, you know, really, you know, have the patient in mind, and, you know, we try to see the patient as an individual as opposed to just a diagnosis, you know. You know, and having experts, you know, from the different disciplines to help treat these patients who really need our help is, you know, makes my makes my job fun, and look forward to going to work.
Awesome. Dr. Krajewski?
My final thought is early screening. Just don't miss the opportunity. Get screened early, as early as 45 if you have no risk factors, because you can save your life by doing so.
Great. Well, thank you, Dr. Krajewski, Dr. Chuong, and Dr. Ucar. Thank you very much for watching. We will see you next time. If you have any questions or want to learn more, please visit MiamiCancerInstitute.com. Thank you very much.